Hi, I'm Dr. Gil Wilshire. I'm a board-certified physician, surgeon, and reproductive endocrinologist. Welcome to my series of podcasts where we discuss medical matters that matter to you. I'll be interviewing top experts in their fields, and we'll also be delving into fascinating backstories from deep within the world of medicine. Hello, I'm Dr. Gil Wilshire. This is the Dr. Gil Show. This is the show where we talk about medical matters that matter to you. My guest today is my dear friend, Dr. Steve Street. Welcome to the show, Steve.
Thanks, Gil.
What a pleasure having you here. Steve is an interventional pain management specialist. And we're going to be talking about pain and its management today, so this should be a very broad interest. It's my understanding that specialists in pain treatment, pain management, come at this field from two different directions. One is usually from anesthesia. I think the other is from physical rehab medicine and that kind of stuff.
That's most common. Also, there's a subspecialty in neurology as well. So we're talking subspecialties of all those. For example, if you're a general surgeon, a subspecialty could be cardiovascular medicine,
Right.
Surgery, cardiothoracic, and same with anesthesia. A subspecialty can be critical care, pain management.
Gotcha. Now, is pain management called physiatry? Is that a real term?
No, physiatry, more physical medicine rehab.
Okay. So I'm learning. So, tell me a little bit about your training. Where did you go to undergrad?
Well, we were talking earlier about my letters behind my name, and if I might have overlooked something. In 1975, in Springfield, Missouri, I went to nurses training, so I'm an RN.
Oh, wow.
Worked in ICU for a while, but I don't know if that's all that germane, but it worked in ICU for a while. And then went to nurse anesthesia training, so I was a nurse anesthetist before going back to the DO program, Kansas City, and then went to interned up at Mayo, and then came to Columbia for anesthesia.
You did an internship in anesthesiology at Mayo Clinic in Rochester, and then you finished
did my anesthesia training here, and then
in Columbia,
and then fellowship out at Syracuse, New York.
Then you did a fellowship in Syracuse at SUNY, I guess that would be.
Well, no, it wasn't with the university; it was private, and it was St. Joseph's Hospital. But and the fellowship was in pain.
How long was your fellowship?
Just a year, and it was a lot of fun.
A lot of fun, where you learn to do these special nerve blocks and whatnot that we'll get to in a little bit.
Yeah.
So you had a long training, and as is true in every subspecialty in medicine, it's many years of training. Now, what interested you in pain management? So you're already doing anesthesia. You probably have a good life. What prompted you to go ahead and get subspecialty trained?
That's a really good question. Actually, I think when I was a teenager, I felt as though, I was kind of looking at different careers, and I thought, it doesn't seem like we're treating pain very well. It's overlooked. I wasn't very sophisticated. I'm just looking at different jobs, and I did when I started doing nurse anesthesia training, it really I could see, pain management was kind of, I'm going to say, in its infancy. That's not true, but it wasn't well known, and it really interested me in trying to decrease people's suffering. And in anesthesia, it's an easy field to think of going into pain management. And so I actually went back to the DO program, became a doctor most likely doing pain management.
Now, was there any particular person or patient or story of somebody suffering? You said, you know what, I can help this person. Does anything come to mind? Was there a formative experience
that? Well, first of all, I think, again, when I was back a teenager, I thought it'd be really cool to do a nerve block and help people's pain go away. And then in nurse anesthesia program, I hurt my back and spent a couple weeks in the hospital, or roughly, or maybe longer, and was really incapacitated. Stayed on a couch for a few weeks as well, and I think that kind of it to the forefront, saying that we're not doing a real good job, or maybe we could do better. And and it turned out, I was saying, do surgery, do whatever you want. I'm really suffering, and I got with a nice, intelligent neurosurgeon. He says, no, I don't think this is a surgical problem. We're going to treat you conservatively, and over time, actually, several months over time, better. I wasn't incapacitated. And it kind of brought it out and said, people are suffering.
You had a profoundly moving personal experience.
I think so.
I think so. That's formative.
Kind of cemented in my mind that would be a good thing to do.
I had one when I was 5 years old. I knew I wanted to be a surgeon at 5.
Oh, cool.
Yeah. These things happen. When someone's in chronic pain, they're not in a good mood, Steve. They're not in a good place. It seems like your job must be very, very difficult.
There's some challenges, personalities and stuff, because of what you're saying. But there's a lot of people vary a lot.
Okay.
Now, I have a father-in-law. He's deceased now, and he got hurt and just destroyed his back. And he was amazing. He had a good attitude, and bedridden some days, and he was just, this is my life, and he enjoyed his life. And it goes to the other spectrum that I'm suffering and I'll never be better, and woe is me, and that attitude that I'm the victim, and I'm not putting them down either. It's a tough life. You have to deal with these personalities. And one thing I think in my favor, and we'll talk about it later, is I'm a really good cheerleader.
Okay.
People are doing well. I mean, I am proud of them, but I even kept pom-poms in my desk.
So this really suited your personality, this field of medicine, I would say.
I think maybe so.
Good for you. A lot of people get pigeonholed into a job they don't like or whatnot.
I felt
you're one of the lucky ones that have been able to find that, the job finds you almost.
Yeah, I think I've thought of it as maybe my calling.
Good for you. Because I can tell you, I've had back pain myself, but I remember when I had a toothache, I couldn't think of anything else. It was so severe. It just changed my life. I couldn't imagine living with this type of pain. And it's my understanding the number one cause of suicide in the days of old was, in fact, dental pain.
Yeah, I would believe that. Yeah, I had some knee troubles for quite some time, and I remember suffering quite a bit, and finally got better. And but every once in a while, I'll come back, and you may not want this story, but I think it's kind of cute.
I want it.
So it'll come back, and it would stay a few days, and it kind of would keep me in the house at least. And I'd say, "Okay, God, I understand. My people are suffering, and you're reminding me how bad it is for them. And I've learned now, and you can stop." But apparently, God might have thought I need to be trained a little bit more, and he didn't do it my way.
That's great. That's great. So in order to be good at your job, you clearly need to be very aware and knowledgeable of the physiology of pain. Just what is pain? Can you tell me what is pain, Steve?
Well, there's a lot of definitions. I think from a clinician's point of view, how I'm going to treat someone's pain, I need to divide it up into what will be effective for this kind of pain, that kind of pain. Many people will think, well, I'm in pain. If you give me a shot in my rear end with morphine, then I'll be better. That is not necessarily so. There's nociceptive pain, somatic pain. So here I'm hitting my arm, and if I was hitting it hard, that would cause pain.
And what type is that?
And that would be the nociceptive,
that's
somatic,
nociceptive pain.
or somatic type pain. Kind of, you'd expect that to be pain. And then there is neuropathic pain, which comes from the nerve itself, like a pinched nerve or a peripheral neuropathy or things like that. And narcotics are not as effective, or non-steroidal anti-inflammatory drugs also are not as effective with neuropathic pain as compared to somatic pain. And so you start dividing things up, saying what will be effective for this kind of problem. But then, of course, then you have to diagnose the problem because sometimes you don't know how you're going to categorize it.
Oh, you anticipated my next question, but let's finish up on the types of pain. So we have nociceptive, neuropathic. Are there any other types of pain that?
No, that's kind of the broad spectrum. You can have central pain if the pain is generated in the brain. That's extremely hard to treat as well, but I would categorize that. Personally, I categorize it as more neuropathic. And then, there's other classifications saying, well, that's not chronic pain unless it's been 6 months or there's different ways to do it. But I, as a clinician, I'll say, if I want to treat this person, let's start classifying it so I can be more effective.
So it's my understanding that there's the signal of pain that comes up nerves. Mm-hmm. Now, they mainly come up with things called C fibers, these little non-insulated nerve fibers, or are there different ways that pain can reach the brain? Does pain reach the brain via regular nerve fibers?
No, it's going to be what you said,
the C fibers.
And let me add to that. There's places in the spinal column itself that have more pain fibers. You can stimulate those with a spinal cord stimulator. Yeah. But also, for example, besides going from the hand up to the brain, pain fibers also can release neurotransmitters and recruit other pain fibers. So now you have pain in one area that starts to spread, and that's very common as well.
Yeah, and I think we're going to talk about that a little bit later, one of these regional pain syndromes. I thought we're going to get to that in a second. Now, I heard something fascinating not too long ago, that they discovered a new pain receptor in tissues that's stimulated by cutting. Okay. Right? And apparently it was new because you figure, well, you get cut, it hurts, but you also think of a razor that's super sharp that maybe you don't feel it, for example. But apparently they just discovered a new, called an organ body or receptor, or some kind of receptor that was new to science, that it releases a painful signal when it is cut, which is different from burning, for example. Okay. Which is different from maybe crushing. Maybe you know these things better than I.
Probably not. I'm not knowledgeable about this real sharp cutting.
Yeah, apparently it was enough to write an article that I read. Yeah. So there's the one component of pain. So there's this signal, this painful, noxious. I guess that's where noce comes from. Yeah. Signal. It's also my understanding that in humans, it may be a little different because you get the signal, but then you think about the signal, you reflect on it. Yeah. Right? So there's the psychological overlay to the signal. Like, use an example. This may not be a good example. Let's say you boil a lobster. People say, hey, you're torturing this poor creature. And I don't want to dismiss that. I'm just using this as an example. Well, I believe one argument is it's a lobster. It's only got a small cluster of cells that you would call a brain. And you put it in the hot water. It clearly receives signals. Let's call them painful. I bet you they're painful. But there isn't this personality on top of it saying, gee, this reminds me of when I was a kid, or gee, I'm not going to be able to get out of this, and oh my God, woe is me, and there's all this overlay on top of it. Whereas a lobster probably feels this strong signal and then dies, and then doesn't have all this layers on top of pain that we might have. Is that kind of accurate? Would you elaborate on that?
I think that's 100% accurate, and I can't remember exactly the pathways because it's been a long time since I've been in school.
Sure.
But there is an emotional component of pain. Not only is there emotional component of pain, it's hardwired in. We have nerves that will go to the emotional component areas of our pain, of our brain, from pain signals. Period. So it
goes straight there.
Yeah, and so it's not when people are suffering. I mean, it's real, you know. And when folks say, "Well, I don't believe you're in pain," all of a sudden, I have several patients that no one believes I'm in pain.
Right.
That they can really be suffering, in particular with chronic pain, because you don't see it. You don't see the high blood pressure or the bleeding, or
Right, it wears them down.
Yeah.
Very, very interesting. So we've got the signal, we've got the psychological overlay to it, and you clearly need to understand how that works. And I've already got a feel how you pick it apart, because obviously you need to know what is causing this pain so you can come up with a solution for it. Very interesting. Now, clearly you need to be able to tease apart and evaluate very complex situations. This is not like, gee, I hit my finger with a hammer so it hurts. These are, which is very simple. You've got a cause, you've got an effect, you've got a very easy treatment, a very simple problem with a basically simple answer. You must be dealing with situations that are horrendously complicated, from age, degeneration, various diseases, various injuries, previous surgeries, damaged emotion, people who are neuropathy. It just seems to me that you are dealing with cases that are horrendously complicated, Steve.
I'm not sure. You might be making me out better than I am.
Or you might be soft pedaling your talents and experience.
But pain is very broad, and so most interventional pain clinics, better than 75%, are dealing with spine pain. The majority of that is lumbar spine pain. But yeah, we're going to see complex regional pain syndromes, headaches, a variety of other things, a lot of post-surgical problems, and abdominal pain that maybe just be adhesions or maybe other things. And so yeah, history is huge. And, when I'm going through things, I want to have their history of what other doctors have found, and imaging studies, and that all the things that help us make a diagnosis.
So these can be lengthy, complicated evaluations. I can tell you, in my field, I don't do just infertility. I take care of pelvic pain, and a condition frequently is the cause is endometriosis, and it's very gratifying most of the time, because after many years of doing this, I'm very good at getting all of it, or what we think is all the disease. Women are very grateful. They're out of pain, or it's much improved. Husbands, like I tell this joke, the husband sends me flowers because his wife's out of pain now. But there's these cases. I have one in particular recently. I took out every speck. It wasn't very bad, so I'm very confident I got it all. I looked around very carefully, and her pain is still there. And I don't know what to do. And there's other things going on. And I just know it feels like I'm over my head, or it's beyond my ability to comprehend. And it's certainly very frustrating because I don't feel like I can treat it. I've used up all of well, here's a great medical term, my armamentarium, all the tools I have, all the bullets I have in my arsenal,
I'll give you an example I see a lot.
Please.
For example, lumbar spine pain. And you see a disc or see some physical problem, and the surgeon goes in and fixes it. The disc isn't bulging anymore. They're fused so that those joints aren't moving anymore. And they still have pain. So you fix there's nothing to fix anymore.
The lesion is gone.
And they're still having pain. That's not made up pain.
Right.
There's no question in anybody's mind post-laminectomy syndrome or failed back syndrome is a real thing. They're really hurting. And I think sometimes that be damaged. It's sending the signal to the brain, or sometimes I think sometimes the brain doesn't perceive.
Ah,
And
you accustomed to it? Do you think there's like an inertia to it?
yeah, I'm not really sure, but I don't. I'm not going to say that's made up pain. I'm just saying that the problem is fixed and they're still having pain, and that's really pretty common. Really bad backs.
So you see it enough.
So
this
you
is
get
a real thing. This is not just a malingerer here or there.
Yeah, 3 surgeries on the back, and yeah, we fixed the problem. I mean, it happens. Am I talking too quiet? Okay, all right. Okay, so we'll get back on track. So anyway, I'm there's no question in anyone's mind they're hurting, but we can't fix it. There's nothing left to fix, and they're still having pain, and that's when chronic pain management does the best that they can, and then a lot of times you use implantables like stimulators and pumps and things like that because surgery is not going to make it any better. Physical therapy has run out of options. Psychological therapy is really hard to get in chronic pain, but if you can get it, sometimes there's limits to what medicine and what we can do.
Yeah, I want to unpack all those things you just mentioned. It's very, very important. Just one more thing that people may not understand about your training and your talents. Don't you have very special tests that you can do to try to discern and pick apart where the pain is coming from or what it's due to?
Yeah, we've talked a little bit about that. The history is awfully important, and find out what doctors have done in the past, and then the MRIs and imaging studies to see, physical clues of what's going on.
So let's stop there with MRIs. You and I are old enough to remember when MRI was new. Resolutions weren't so good, and like everything in medicine, they get better. All the technologies, at least, they get better and better. Have you seen much improvement in MRI, or can you tell me how MRI is helpful to you?
Certainly with spine pain, it's just that's the go-to imaging study.
The go-to. What can you see? How small of a thing can you see on MRI?
Oh well, radiologists are really good at reading MRIs. So I'm going to defer to them and their expertise because they spent years learning that. But yeah, they can see arthritis changes in facet joints and joints in the spine, and this disc is pressing on the L4 nerve. They can see things like that. So it's a really good imaging study. And the patient's physical exam, what their pattern of their pain, where they hurt, is you can, for example, you can have easy example. You can have a disc that should be pressing on the L4 nerve, but they're having pain down the L5 distribution. So you have maybe 2 discs, but one's little, one's big. Well, maybe the big one's a red herring.
And you can ascertain this.
Well,
with an examination.
Yeah, from their sensory pattern of pain. And then interventional pain management will allow you to go in and do a nerve block. You can do it on, let's say, the L5 nerve, specifically for that. And if their pain gets better, then we're in the right spot. Let's direct our care for that patient with the
target. So you've got MRI, you've got very careful special physical exams you do. Are there any other tests you do? Neurologists do EMGs.
Yeah.
Is that something you might do? Test the nerve itself?
Well, yeah, we ask the neurologists to help us. So they'll do nerve conduction studies and help lead us in the right direction. Is this a peripheral nerve problem, or is it a pinched nerve problem, more of a spine? Things like that.
Yes, you have to be knowledgeable of that and of advances, and you have to have a community of doctors that you trust who will help you out on these things sometimes, I guess.
Yeah, and same for treatment. I mean, sometimes you send them to a surgeon. We don't like to do that but I think it's better than suffering. And chiropractic care, physical therapy.
Well, now that you mention it, chiropractic. I had a very bad skiing injury when I was 18, which really messed up my back. And I'm very grateful to one chiropractor in particular who took care of me and nursed me to health. I was never the same, but I got much, much better. Do you have any general feelings about chiropractic? This is a huge topic, and I don't want to make oversimplified or make overgeneralizations. But do you have any feelings about how chiropractic can be helpful for chronic pain, and especially back pain, obviously, and maybe where it falls short?
Broad topic. I know there's some prejudice from the medical community, and I shouldn't really just say the medical, but let's say MDDOs about chiropractic care, and I think that's wrong. It's clear that they can help with pain, and I utilize them. I appreciate their help. I mean, my philosophy is hit them with everything we got. Hit them with medicines and nerve blocks and steroids and physical therapy and chiropractic care. That's all. Do what we can. But I think your point of trusted colleagues, because sometimes you'll find an MD that I'm just uncomfortable with, and same with chiropractors too. So I don't know if I answered your question, but it's broad, and my personal feeling is yes, I want their help.
That's good to hear. Because if you talk to a chiropractor, I bet you virtually every chiropractor you talk to is going to point to patients that traditional medicine wasn't helping them. They came to me, and here they are walking upright and able to function without pain. That's a typical day for a chiropractor is helping the things that we might fail at.
Exactly. And so I think it's wrong to have for me, it's wrong to have such a prejudice.
So sometimes psychological counseling can help or something. Obviously, it doesn't go necessarily to the root of the pain, but it goes maybe to the understanding and the reaction to it, I guess.
Yeah, and the coping, because we're talking about pain management. We're not talking about pain cure, because
it's a good point.
It's hard to cure pain.
Good point. And there's physical therapy, and I'm aware that physical therapy has waxed and waned depending on reimbursements, Medicare reimbursements, and what insurance pays for and doesn't. I know for a while there, every strip mall had a PT place because reimbursement was so good for what ended up being, a fairly small investment with a high return. But I can tell you, when I had my shoulder surgery, my physical therapist, the first person to take me out of that sling and work on it, they could do no wrong. I worship that therapist because it hurt so bad. I had my arm out, and then in a few weeks, we did dangling and getting out of pain. Meant the world to me. So clearly, physical therapy has a role in pain management. Then there's these adjunctive things for pain. Can you think offhand? Can you kind of generalize what other little things you can add for pain? Anything that you think is underlooked or overlooked or underappreciated, or maybe given too much credit?
Yeah, and I guess here I'm going to have to backstep a little bit because I'm saying let's hit them with everything I got.
Right.
But I'm traditional, and when you start doing now, okay, there's one exception, but I'm more traditional. If you start talking reflexology or aromatherapy, I'm not so sure that's going to help. I've never told my patient don't do that, because if I'm wrong, that's the best. Being wrong, I love it.
Sure.
But I also kind of say I'm not a big fan. I'm more traditional, except acupuncture.
There is a role. There's a scientific basis for acupuncture,
and it's been around for so long, and it's helped. It's just hard to overlook that. To say that's all fake. Now, there's always people 2 bubbles off that I can cure diabetes with manipulation or stuff. Right. But I think if we all stay in our role, like I should stay in my role, I think we can help folks, including acupuncture.
I think we're both old enough to have seen changes and evolution and improvements in our fields. So maybe we can talk about some things that have changed over the past 30. I think we've both been in practice for over 30 years. The first thing I think we should talk about is the changing role of opiate medications. It used to be they'd throw. I mean, in the early days of OxyContin, the drug reps would come around and say, the vital signs are your weight, your temperature, your blood pressure, heart rate, respiration rate. They said, no, there's another vital sign, and it's pain. And if you're not addressing the pain, then you haven't done a full job here. And your job is to have them walk out, be pain free. And that's when they push these narcotics. Now, can you talk about how you've seen an evolution, the pendulum swing for opiates and chronic narcotics for everybody to now where the pendulum has swung?
Yeah, it's absolutely crazy, and I sure wish that the people making policies and recommendations, including doctors, would just say, just calm down and do what you've been trained to do, and do what's best interest in the patient.
Because here in Missouri, we were the last state to have electronic records, collected by the state and the insurance company, but by everybody. Like every narcotic prescription around the country is databased and tracked. And Missouri was the last one. The state held out. So I kind of interrupted you. Take us through the past 20, 30 years of opiates.
I'll start as an RN.
Oh, good.
And as a RN, kind of the philosophy and the feeling in the medical community at that time, this was back in the 70s, was, no one, you can't give a lot of narcotics because they're going to be addicted. And you're just going to have to stay away from that. We'll give it short term. They had surgery or whatever, but you just can't put them on. Well, and then it evolved to, if they got cancer, who cares if they're addicted? If they got cancer, let's treat them with narcotics. No, there's some things that are worse than cancer. Living with pain all your life. So we can treat those people with narcotics. And then it became the fifth or sixth vital sign. And then, people shouldn't have to suffer and they should be on narcotics. And it really swung from the 70s to the early 2000s. How things changed and were much more liberal with narcotics.
Yeah, swung too far.
And then obviously the result of that was a lot of people dying from overdose. And, I even heard early in my practice of a fellow that was being sued or threatened to be sued because he didn't give enough narcotics because the person was suffering. Or, you could also get sued because you gave too much, and there's complications. So it really was, it's crazy. And I think now we've swung to wanting to regulate the doctors and sue the opioid makers. And maybe that's good or bad. I'm not going to go into that, but it's really, I've seen a lot of change. I really
certainly think, swung the other way now.
Yeah. And I really think looking back at my training, I'm going to do what I'm trained to do. And we're going to, opioids is a useful tool, but it's not the only tool. And it's very clear when we're talking about neuropathic pain and other things, there's other options. In my practice, and I'll have plenty of patients that will back me up, the combination, the multidisciplinary approach and the combination of different therapies is better.
Mm.
And certainly we've had my fair share of people coming in and not agreeing with my treatment plan and only wanting opioids. And
sure.
But my preference was not to do that. I do the full spectrum.
Yeah. And one of these unintended consequences of cutting these people off or making it so hard to get narcotics that might be appropriate is then they turn to the black market when bad stuff happens.
And exactly. And so was it 5 years ago, a few years ago, the CDC came out with recommendations on the upper limit of narcotics.
Okay.
And that was very difficult for chronic pain patients.
Morphine equivalency. I remember.
Exactly.
Yeah, these tables.
And then more recently, now the CDC has come out and said, "Oh, we didn't mean for that to limit the doctors how much they should prescribe." However, if you look at their initial, and I don't agree with what they just said, but they kind of reversed that and said we don't want to tell doctors what to do. You should treat their pain. We didn't mean for this to harm chronic pain patients, but it did. And so I think they're allowing us to, they're saying go ahead and do what you're supposed to do. Unfortunately, through that, maybe some of the doctors agreed or didn't agree with the CDC, but the insurance company could say, no, we're not going to pay for more than 90 milliequivalents or equal potent doses of morphine.
Yeah, the other doctor in the room, the insurance rules.
Yeah. And so as you can tell, I've had a lot of frustrations with them. Yeah, because, for example, the psychological care or physical therapy is not paid for very well. Yeah. So it's hard to implement those.
Yeah, I'm going to have more than one other podcast on costs of care here in America. Insurance companies are going to be in the spotlight. They're coming. Now, there have been new drugs and new uses of old drugs, I understand. I don't know, maybe it was 5 years ago, I was treated to a very nice lecture and some food about a company that had a new medicine made from snail toxin.
Yeah.
What was that all about?
I was one of the people that got to part of the trials. I had patients, and the company, I was an implanter, implanted pumps. And so the snail toxin, really interesting history, by the way, but I'll go ahead with this part. So they would pay for a pump implant and then provide SNX 111 is what it was called back then. Now it's called Prialt. And or is this Conatide is the brand, generic name. And we would run that medicine from the pump into their spine. It's all implanted underneath the skin. Unfortunately, back then, we were researching to find out what would be a therapeutic dose, what was effective with minimal side effects. And at that time, it was causing a lot of side effects, but we were way over the doses what we would use now. And it really wreaked havoc with I had one fellow that was out driving his truck around that he hadn't drove for 3 years looking for his dead friend. Died 7 years ago. He was trying to find him, and the air conditioner was talking to him. And so it really, really caused a lot of problems. It was nice to get off of that study. However, Prialt came to market once they figured out the dose,
the right amount,
much less than what we were using, and it was a useful tool, or is a useful tool. I can tell you, my personal opinion, it's so expensive, it's really hard to use, and I've used it in combination with other medications, and fairly effective, but you really have to watch the psychological, the cognitive deficits that they get. And so I personally don't use it very much anymore just because of that.
Yeah, so that's a brand new drug. Are they doing things with ketamine? I've heard that ketamine, it was that horse tranquilizer or something very, very old. It was called a dissociative drug. Are they finding new, it's my understanding that they're finding new uses for this old, cheap drug?
Oh, it's came out in the 19...
It used to be cheap.
It still is if you get the... Anyway, came out in the 1950s. It's an anesthetic drug that I've used on patients quite a bit. It's very unusual in the sense it's not depressing your vital signs. Actually, if you give a dose, it'll bump up the blood pressure a little bit. Military uses a lot for field pain relief, and actually they're using it now for trauma in the field, they'll give a big dose and it appears to be decreasing PTSD because it kind of scrambles, one way to say it. In anesthesia, we use it if you use anesthetic doses. It'll put them to sleep and they don't remember anything, but you have to be cautious because they can have hallucinations, so you got to give a drug up front to try to avoid that. But what a painkiller, and not on the opioid spectrum. It works in a different way, and it is very potent painkiller. I like it.
It's not addictive, and you're controlling how they get it.
I don't believe it's addictive. I mean, it certainly could be psychologically addictive because
but
it's
not in the same way you equate with opiates.
Yeah, because it's special K, they call it on the street, and they use it. And it's like you said, it's dissociative, so they're going to have changes in sedation and then also can cause hallucinations. But used appropriately in small doses, it is amazing pain relief. And they're using it for, well, it used to, it was not popular, but it was well known that ketamine will treat depression very, very quickly. And in fact, a suicidal person sometimes could give a big dose of ketamine and they come back feeling a lot better real fast. But it's hard to get an anesthesiologist up in the middle of the night to come in and give a induction dose of ketamine for someone that's depressed that's not going to have surgery. It's counterintuitive, and so it wasn't used very much. But they're finding new uses for it a lot. I've used it for pain when everything else didn't work, and it works. They're using it for complex regional pain, and it's appeared to be working. They're using it now for depression in lower doses, and so it's a cheap, effective drug.
So I'm hearing that the field's continuing to evolve.
Yeah, the problem is that one of the problems is you don't start with this drug. It's kind of rescue when everything else fails.
Now I'm hearing some interesting things about low dose psilocybin for depression or other chronic mental illnesses. Have you heard any role for that or other non-traditional drugs for pain?
No, I have not. But I in my brain, I liken it, or I kind of put it in the same category of ketamine. But I'm not burdened with a lot of facts there. So that's just how I classify it.
So I learned something already from you, that you said something like 70% of your practice or people you treat have pain that comes from the back or the spine. Interesting. Are those mainly pinched nerves or swollen discs or something? Or is there something else I'm missing?
No, there's a variety of things in the spine that can cause pain.
Like what?
Alluded to the joints, the facet joints. You can have arthritis in it, and that can cause pain. And that would be more somatic type pain. Discs themselves can degeneration and all, have discogenic pain. And that can be diagnosed with pressurizing the disc.
Re-inflating it, you say?
Yeah, you can put dye and pressure in the disc itself and mimic the pain that they have. And also, when you put the dye in, you can do CT scans and see how the internal anatomy of the disc is.
I knew you had more fancy tests we hadn't gotten to. There you go. Yeah. Now they're coming out.
So there's discogenic pain. You can have pain in the joints. You can have pain from the vertebra itself. And then you can have pain from the nerves too. And unfortunately, you'd like for it to all fit in one category. Okay, this is somatic pain, and we can treat this with blah, 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 blah. But often with the back, it's going to be a combination. One way I personally would decipher that is I would do an injection in the joint or do an injection along the nerve root. How much did that decrease your pain? Was that successful?
Okay.
Did it help 90%? Or, tell me, was that helpful? Or was it not helpful? It only helped 20%, And these percentages are just for me. You know, I'm wanting to know to the patient, from the patient, was this useful, or should we abandon this and go on to another
something that works
that may be causing you pain? So I'm using these injections to say, yes, I'm doing the right thing, or no, let's move, diagnostically, let's move on.
So let's briefly talk about the other 20 or 30% of pain that's not bad. Can you just give me some idea what we're looking? We're not looking at migraines or joints themselves, like degenerated joints that an orthopod would treat, or am I wrong?
No, we'll see those folks as well. Sometimes, for example, I have one very nice lady that has migraines, and the neurologist has Botox injections, and
they give Botox around the forehead or something?
Yeah, and you can also do the great occipital nerves.
Is that something you would do, or we're more the ENT or neurologist?
Both. And then, but then, so they're doing all the things and having her on the right medicines, but she responds well to opioid, a little bit of opioid. And he says, I'm not set up to do that. I don't do urine drug screens, and I don't check the database every time someone comes in. Right. And will you take care of her? And I look at the history. Yes, this is migraines. I look at the treatment, what's going on. Yes, I strongly agree with what's going on with the treatment. We're not overlooking things. We're not just giving her narcotics. So yeah, let me help.
So they'll turf that over to you.
Yeah.
And I would assume that the powers that be would give a pain specialist like you like a little more slack, a little more deference to your judgment on opiates.
I think yes and no. You gotta. The DA and everyone's going to expect you to do urine drug screens, and are they taking their medicines? You just can't overlook that sort of thing. So you're going to have some documentation. I don't know that it's a law, but it's expected. And if you don't do that, I think you're going to get in trouble.
So there's standards of care that you would be aware of to follow.
Right.
Being a pain specialist.
But it's easy for me to follow because my whole clinic's set up to do that.
Right.
Where a neurologist that doesn't do that, it doesn't have those tools. It's already set up. And so I think, but for example, they track prescriptions on doctors. And and just like if I was a infectious disease doctor, I would write a lot of antibiotics.
Right.
I think as a pain specialist, if I write opioids, that's going to be kind of expected. He's writing more than a family practice doc, but that's a specialty.
Gotcha. Is there anything else I missed? Because the reason I want you to list out these types of pain issues that you treat is I want to help somebody watching this podcast. I've got this problem and I'm not getting help from XYZ. Right. What other diagnoses or types of pain would be appropriate to visit you or someone like you who's a chronic interventional?
Yeah, I think one that's hard to diagnose used to be called reflex sympathetic dystrophy, and now it's CRIPS 1 and 2, chronic regional pain syndrome.
Regional pain syndrome.
And so, and I used to be I'm pretty knowledgeable about it. In our fellowship training, we got to unfortunately see some people. For example, I had a firefighter come in with a broken, I think, finger. Trauma at work. So if something pretty not real bad happens,
should heal and go away.
Yeah, but it's almost always, in fact, it's always caused by a trauma, and but it can be a minor trauma, and the involuntary nervous system starts sending pain signals to the brain, and that's abnormal. It should not do that. It should be the C fibers and all that stuff, and then it will recruit, like we talked about earlier, it will recruit other nerves.
Oh my goodness.
And so now you have some weird symptoms going on, starting in the little finger, let's say, of pain that's out of proportion to the injury. For example, if you would stroke it lightly, that would be very, very painful. You're saying, whoa, what, and it's swollen, and it's red, changes colors from red to bluish. Your vascular system, involuntary nervous system controls the vascular system. So you're getting dilation and contraction of the blood vessels, and it's changing the colors. It's swelling, and you're leaking into the periphery.
These are clearly demonstrable abnormalities.
Oh, yeah. And then your skin changes, and your nail growth changes on one hand as compared to the other, but it starts spreading out the whole hand and up the arm all the way. Usually limits itself to one extremity, but it can spread on the firefighter's case into the same. It spread into his leg where he was in a wheelchair, and can destroy your life. It's awful. It's a terrible nerve type of pain where narcotics don't help very much. That actually is curative if you block the involuntary nervous system is set up where we have ganglia. So a lot of the nerves for that area comes into one switch box,
okay,
and then goes on. If you can block the stellate ganglia right here, a series of blocks started early, it'll cure them.
And can you do that?
Oh yeah, yeah.
That's one of the things you do. It's
yeah,
in your wheelhouse.
Yeah.
Did you treat this firefighter?
Actually, we got to him late. It was in my fellowship. And it spread. It was just awful. In fact, he lost hair. Hair growth changes and everything. And so that's why it brings up to mind that he did not do well. It was turned into a bad condition for him. But yeah, I've seen people be cured.
Because when I was reading about this before this interview, I went to, Google, of course. And one of the first things that came up said, condition is permanent.
Yeah, well,
or it could be permanent without treatment.
Yeah, with early treatment of CRIPS or RSD, I've seen many people cured with a series of injections. And there's a lumbar plexus back here. You can do the leg.
So I should safely say that if a person is diagnosed with this regional pain syndrome, see a pain specialist like you ASAP.
Yeah, I would strongly recommend it. And the symptoms are so bizarre. I mean, Doc, my nails are growing faster on this hand as compared to this.
On the bad side, they grow faster?
And who would know what to do with that, And so it's just such weird symptoms. And so it's may not be able to get to them in time, but I've seen plenty of people cured with but I've only seen one cured with one injection. Usually it's a series. And no one likes a needle coming at their neck. You numb them up good. It's a little bitty needle.
Well, that's fantastic. That must be very rewarding.
Yeah.
Any other pain issues before we get back to spine? Any other pain issues in the body where you think an interventional pain management specialist such as you might be the person to turn to?
No. Can't think of anything off the top of my head.
Migraines and regional pain.
Yeah. I mean, there's other things.
If it's joint pain, I know the orthopods and whatnot, they'll inject numbing medicines, steroids, what have you, into peripheral joints, and they'd be as good as you probably.
Yeah, I think they're very good. Yeah. In fact, I've had it done to me.
Gotcha.
Loved it. By the way.
I imagine doing your own stellate.
No, I'm not going to do that. But they're very well qualified. There are some things that we can do that orthopedic surgeons probably, for example, let's say a knee, a person medically is not safe to go ahead and have surgery and they have a joint that's destroyed and need a total knee replacement. And there's some things that we can do to manipulate those nerves and heat them up where the nerves don't work anymore for the sensory part of the knee. And so they're not suffering as much, but it's not curing the problem. It's just saying we can't cure the problem. Let's see if we can decrease your pain.
What is the expression? Unmasking the face of pain? How does that go?
Oh, that's me.
What is it?
I cloak the shameful nakedness of pain.
You cloak the naked
shamefulness.
Shamefulness.
It's shameful.
Shamefulness of pain. I love it. I love
Yeah,
it.
yeah.
I
And
love
then,
it.
and that, you take that to the spine, the joints in the spine, heat up the nerve that goes to that joint, decrease the pain. But nerves have a tendency to try to grow back. So
Gotcha.
that's why, for example, you don't want to do an alcohol or a phenol nerve block that would be quick and easy and kill that nerve, because the nerve will grow back. Sometimes it'll cause a neuritis because the nerve grows abnormally. Or you do it with a prescription of heat through a needle. And it doesn't destroy the sheath. The nerve can grow back normally because it's going to try and grow back. It'll try and grow back no matter what you do. That's how God made us. And so it's not really fixing the joint problem, making arthritis go away, but it's decreasing pain, hopefully for months to years.
And if they're not physically fit, or it's not healthy enough to have the surgery, at least you've relieved their suffering.
Yeah, helped.
Good for you. Good for you. So let's go to the majority of your work around the spine. It's my understanding you can block nerves like you've just been mentioning. Maybe we can talk about that a little more. It's my understanding you have electrostimulators that you can implant. And as you've already mentioned, you can implant pumps, which can instill or infuse or deliver some type of therapeutic medication to help pain.
Yes.
So that's a huge topic here. So when would you, well, let's finish the thought. When would you block a nerve in the spine?
I think of two reasons to do it. One is we put some numbing medicine on that nerve and see if that's the nerve that's causing the trouble. Let's do nerve pain. And while I'm there, and let's put some steroid there, because if I am right in my diagnosis, my physical exam and history and all that stuff says it's an L5 nerve. So I go down next to the L5 nerve under x-ray and put numbing medicine. I might as well mix in a little bit of steroid, and because the treatment, hopefully the nerve is inflamed and we can decrease the inflammation.
Lowering the pressure in there, decreasing
right.
inflammation.
And so now, and within a few minutes, I'm going to get information I need to know. Was that the nerve? Did your pain change significantly? Well, good. If it did, we've already started the treatment. Try to do a series of steroids that will decrease the pain for hopefully months or longer.
That must be a very, I don't want to say difficult, it just must be tricky. You must have to develop a touch over many, many years to be able to get a needle right where you need to get it. Well, I've heard, well, by the way, folks, I have heard that Steve is just the master at nerve blocks and can put a needle on the hair of a gnat on the back of the wing of a.
No, I've never tried that. Technically, I use a very small needle. Big needles hurt people. Numb them up real good. Bend it a little bit so I can steer it.
You can steer a needle like the oil drillers. They can steer the bit now of the
except on
drilling.
a much smaller scale.
Yeah. You're not grinding a bit down in there.
And you do a few thousand, and it gets pretty routine.
I bet.
I wish we could find the depression nerve, because I'm convinced I could get it.
So, electrostimulators. Tell me about electrostimulators. I know they can use them in the brain for Parkinson's now.
They do it for pain too.
And
I don't do that. That's neurosurgeon territory.
So where is your territory for electrostim? Once you get out of the head?
Yeah, in the spine. Or a typical one would be post-laminectomy syndrome. They've had surgeries and their nerve is still hurting them. And so we've said...
let's turn this into English. They've had an open surgery, a big surgery,
right,
where the surgeon has gone in and opened up these spaces,
right,
these rongeurs. They literally open up the back of the back so the nerves should be free. I don't know how the back works afterwards, but somehow they kind of put them back together. So they've had this surgical treatment, and they're still in pain.
Or 2 or 3.
Or 2.
And now I had more than one fellow that had 12. But
12 back surgeries before they came to you.
Yeah. But
wow.
so anyway, then what I would look at is where is your pain coming from? Nociceptive neuropathic, and let's do a physical exam and see if oh gosh, to me I think it's an L4 nerve. Let's go down and block that nerve with a little bitty needle and see if your pain gets better. And while I'm there, I'm going to put some steroid in just in case we get lucky. But now I know that he says 90% of his pain is coming from the L4 nerve. And surgically, there's nothing, it's fixed. There's nothing we can go in there and correct. And occasionally I would heat that nerve up. That's not common in the United States, but
could be done. That there'll be a type of block.
Yeah. And when that worked, it was fantastic. And sometimes it didn't work. Everybody knows that when we're going in, right? Everybody's on board. And then let's say everything failed. The option is to hurt. Well, if the majority of the pain is coming from a nerve, you can put a spinal cord stimulator in.
Now, you think a stimulator would make it worse? Well, what's going on?
So
here?
you're stimulating posterior columns where the pain comes up, the back. The pain fibers are in the backside of the spinal cord. So if you put in a wire, a lead that has electrodes on it, position it correctly and run current through there, different currents that different companies recommend. You can stimulate that. They'll feel on at least one type of current. They can feel that, yeah, I'm covering that painful area now.
So it stops. So by sending an electrical signal, you've it's a different kind of block, I guess.
Right.
Saying.
And if it's successful, I'd have them go home for a week, try it out. If it's successful, you implant the whole thing underneath their skin. And then they have a hand.
Oh, so there's a transition. So you put the electrode in, and then they're wearing a device or something,
exactly.
on a belt or something.
Yeah, exactly
okay.
correct.
Okay.
And if it's successful, at home, because I don't want someone spend the night in the hospital with extra pain medicine. I come in tomorrow. Are you feeling better? Yeah, let's go implant. That's not how we're going to do it. We want them happy 5 years from now. And so they try it out and come back and talk. It's decreased their pain significantly with activity, within reason. We can implant the whole system underneath their skin, and hopefully that will decrease their pain for years to come. Now, there's other products out that stimulates and they don't feel it. It's at much higher rate. It's 2,000 hertz.
They don't feel the stim.
Correct.
They don't feel like
right.
or whatever.
And that can decrease their pain too. Some folks are saying that's a better way. They're covered. They're catching more.
So this is something you do. You can get an electrode onto that part of the spine.
Right.
You can then make a pocket or something to get this device in there and sew it up, and it's in their body.
Right. And the new technology, that's really been fun to watch the technology change for the better. It's rechargeable, so it's going to last 9 years. You recharge it up instead of a battery
Can
going
you
out.
charge it through the skin or something, like your phone on those things? Yeah, so you don't have to cut and make a new battery insertion.
Yeah, you have to replace it years down the road. Then they got new fancy programs that used to, when I did it a long time ago, I could program everything and I could test it, but now that's so high tech, I got to get
flying your RC plane. You got your little toggles. And,
I could figure it out, but now they're so fancy. I kind of go.
You need a kid,
help me out here. I don't have the knowledge you guys do.
So a stimulator. We get this straight here. So a stimulator. I would think that electrical shocks would make pain worse, because I remember when I had an EMG and they shocked me, it hurt like hell.
Yeah,
but it works the opposite way.
Yeah, and for example, the gate control theory of pain. And so it may be a distraction, or we're not 100% sure how it works, but it's significant.
But it does.
Oh, there's plenty of people out there. Jerry Lewis had a stimulator in him. I remember he's on Johnny Carson. I feel it. The generator's right here, and I have 100% pain relief. And everybody's going, "No, don't say that," because you don't normally get 100% pain relief.
Right, and then the next day the phone's rang off the
Yeah,
hook because I want what Jerry Lewis had. Yeah.
And no, we don't start with that. We don't start with multiple tens of $1,000 unit. We start with what's wrong with you first.
All right, then. So what are these infusion pumps or these implantable drug delivery pumps?
Right.
What can they do?
Well, there are what most people talk of the morphine pump. And so what you do, what I would do is do a trial to make sure pain medicine in their spine helps them. And if it does, there's different ways to do a trial. If it does, then you go back and implant the whole system underneath the skin. And it's about the hockey puck size pump.
Okay.
And a little silastic plastic soft tube comes out of it, goes underneath the skin to the spine, and goes into the sac of fluid that surrounds the spinal cord and gives pain medicine. The FDA approved medicines, the pre-alt, we already talked about the snail thing. And then there's morphine, baclofen. I think that's all the FDA approved stuff. However, sometimes those three aren't good enough. And if you're going to wait for FDA to approve things, then you will suffer. And so we'll do off-label use of medications.
Compassionate use.
Yeah, and realize off-label use is not wrong. 1985, FDA came out with a position paper saying if we approve of a medicine that's FDA approved, we're saying this medicine is safe. We're not going to tell doctors how to use it. You can use it for whatever problem you want.
Sure.
For example, Elavil is an old antidepressant, but it also helps with nerve pain.
So you can put some Elavil in the cocktail.
No. Yeah, oral. But you know what I'm saying. You can use off-label use is not necessarily bad, but it's there's a but insurance can say, well, if that's off-label, we're not going to pay for that.
It's not turpentine.
I'm still. So here I'm back on the insurance thing, but.
In my field of reproductive endocrinology, we borrow medicines from the oncology, the cancer world.
Really?
Because they also work on estrogen receptors and
sure,
and pituitary receptors, and we use it for the endocrine outcomes.
See,
safe, effective, old, cheap.
Very grateful you're in that field. Way out of my arena. Wouldn't have a clue what to do with it.
That's why we have specialties here. So you said in the cocktail, you can have a little bit of morphine, you can have a little bit of baclofen, you can have a little bit of the snail toxin. What else might you find?
Pretty common with the pain practitioners. They get together once a year and kind of go through care and what they use. Bupivacaine.
An actual anesthetic.
Yeah, and give a light dose of that is pretty common.
I'm sure you go to conferences and on the exhibit floor, there's a pretty girl running around in a snail costume.
No.
No. Because I can tell you, in the OBGYN and urology field, there's always a place for the erectile dysfunction drugs that they'll have they'll have quite cute little saleswomen kind of,
I bet that's entertaining.
Detailing the medical benefits.
Yeah. Bless
Trying to get your attention. So no people in snail outfits.
No.
In your conferences.
Not that I've seen.
So these infusion pumps that's going into the spinal fluid, usually is that where it's going, or is it going into the space called the epidural space between the outer membranes of the spinal cord?
No, it's inside the sac of fluid that surrounds the spinal cord. So it's inside.
So how does it stay there? Or does it in fact travel up and down?
Oh, yeah. For example, morphine will travel up into the brain. And so people say, no, that only helps my back. That's not true. From nose to toes. Really.
From nose to toes.
Right.
So you're getting in this, so that infusion pump could go in almost anywhere then. Is that what you're saying?
Yeah, and so we like to put it in below the nerves. Thread the catheter up some.
Down the lower aspect of the spine, which is safer.
Correct. Because we're
just
down
for
below.
people who who may not know the anatomy, the spinal cord actually only goes down 2/3 of the way down your spine. And then afterwards, it just sends these tails called a horse tail. And there's these little nerves that move around. So you put a needle in there, they move around. It's more forgiving.
Yeah.
Less likely to damage the spine.
Right. And so now there is some, for example, using numbing medicine, it's nice to be at the level where they hurt. You're not going to numb them up. You can't give them that much numbing medicine, or they can't walk, or they can't move their arms, things like that.
And so specifically, what type of pain syndromes or pain problems would you use an infusion pump as opposed to a stimulator?
Well, the old-fashioned me, it would be more nociceptive pain, but it would be everything else has failed. We've had surgery. There's nothing to correct there. We've tried oral medicines. It's not working very effectively. And we start looking at implantable pumps. The huge advantage of pumps, it's just a different way to deliver pain medicine. But the huge advantage of pumps is, for example, morphine. I can give 1/300th of the dose in your spine than I can with, it'll be the same as giving 300 milligrams, let's say 1 milligram in your spine, 300 milligrams by mouth. And so as I start bumping up their dose, I can get pretty good, most of the time, we can help pain quite a bit. And our side effect profile is low. And so you can give a dose that would almost kill someone by, equal potent dose by mouth. And so you're allowed to give better pain relief.
So there'd be much less tolerance because you're just not getting used to it. They're not getting addicted. Anything.
Well,
like that?
Yes and no. If it goes off, if you stop them all at once, most of the time,
you don't want to do.
When you get to a moderate dose, they'll have withdrawals. Now there's another dosing regime that is newer, and it's microdosing, and that would not be the case. And the microdosing has less side effects and complications, but sometimes they don't get as good relief too. And I'm speaking from the 25 years experience. Some people out there will argue with me, but that's my opinion.
We'll have a much better idea now about what you can provide. Now, is there any? You probably have hundreds of them. But is there any story, any particular person that failed everything else, and then Steve Street came in and totally turned their life around? Can you think of one example out there? You must have hundreds of them. Dig out one for me. One story, heartwarming story for me.
Actually, Kenneth died probably a decade ago. So this is probably not a heartwarming story.
But from something else.
But yeah.
So you had a patient. His first name was Kenneth.
Yeah, and nice guy. And his wife was Dolores, and they loved each other. They love each other a lot. It was really cool to watch how that interaction. And when you're dealing with people that have chronic pain, often I'm dealing with them for 20 years, and so they know about my kids, and I know about their kids.
Yeah.
And so everything had failed on this husband. Nice, really nice guy. Somebody you want to live next door to.
Yeah.
And I don't remember saying it, but he said later on, he says, "This is going to change your life. Let's do this."
You told him it was going to change it. It had potential to change his life.
And I don't remember saying that because it's not like me to have guarantees. But anyway, he went through it, and he said, "It changed my life." He was just thrilled to death. Unfortunately, his wife developed spine troubles. Everything failed, and she ended up with a pump too. In fact, I was reluctant to even go down that path because I just don't have couples on pain pumps. And she said, "Can I have one?" You are a candidate. So now I'm treating. Survives him. She's awesome too. I don't get to see her very often, but good people. I'll tell you a story. When I was working in a clinic, it was in a basement. Doesn't matter. where it was. And a little lady comes in, and she's sitting on a gurney. And I'll never forget her. She's sitting on her legs are straight out. She's sitting up in the gurney. And I'm chatting with her and all this. And she goes, I told Dr. So-and-so that my left leg really hurts, really bad. And he says, well, you're 86 years old. You're going to expect some pain. She goes, yeah, but my right leg, it doesn't hurt.
It doesn't hurt.
What she
got
was,
a control limb. Thank you very much.
and so what she was telling him, and I strongly agree, just because you're old, you don't have to have pain.
Thank you, Steve.
Yeah, but that's what she was telling him. And I go, yeah, I think you're right. Let's try and help. Let's not blow you off.
Listen to the patient. And you listened to her and you helped her?
Yeah, she improved.
Well, that's
when you have
wonderful.
to listen to them too, because sometimes you get clues on where the pain's coming from.
Right.
I mean, there's sensory exam. You can do it. Talking to them. Does it hurt? Does it hurt in your big toe?
Yeah. So I'm going to use this to just to champion the concept that if you go to a doctor for any problem, you need to find a doctor that will take their time to really evaluate you. Now, I know a lot of doctors nowadays, and this is going to be a topic of another podcast. Poor family doctors who only have 5 minutes to see you because they have to see 6 people in an hour, and most of their life is doing a chart. But if you can find a doctor who has the time to carefully evaluate you and listen to you, and be able to formulate a true intelligent assessment, then they're the ones that can usually really help you, especially if you have a complicated problem.
I want to echo what you're saying, and also compassion goes into it. Yeah. You kind of go, I really need to figure this out. Take some time to listen to the problem.
Yeah.
Don't miss them.
And patients may not realize that you may have left the room of somebody who just yelled at you, who just had a bad outcome. You weren't able to help them. The spouse wants to beat you up in the parking lot and all this stuff. And you have to walk out of that door and knock on the next door and go in. And go in fresh like that never happened. And find the compassion. And do this all day, every day, year after year. And I just want to let you know, Steve, that from the people that I know that know you, that you've been able to find that place with compassion. And we're not perfect. I'm not calling you saint. I'm not calling you Father Teresa or something like that. But you are one of those rare doctors who is able to find the compassion, especially when you're having a tough day and you may not be appreciated by all your patients, despite how hard you're working. So that's my segue, Steve.
Very kind.
Thank you, and I mean it. We live in a small world, and word of mouth travels very effectively sometimes. So I'm going to lead to our final topic on this interview, and that you have experience beyond just pain control, because you, over the years, obviously seeing people in severe pain, chronic pain, have dealt with people who've had to take large doses of narcotics for a long time. People become addicted. Anyone, I use Father Teresa, like I like to say, Mother Teresa, if you put a morphine IV in her arm for 6 months, she's going to get addicted. Anyone will become addicted to narcotics. And you have experience giving and running clinics with the medication called Suboxone, which helps opiate addicts recover. Tell me a little bit about Suboxone. I'll help people. It's a combination of 2 drugs.
Yes.
There's one drug. There's a mixed agonist-antagonist. It can be used for pain, but you can only take so much. You can't get past a certain point. So it helps a little bit. So it kind of blocks itself in a paradoxical way. And Suboxone also has another a pure opiate blocker called naloxone in it, which people give if somebody's having an overdose. If an ambulance finds someone overdosed, they'll give a spray or a shot of this naloxone or naltrexone, and it blocks the opiate. But apparently the combination of these two drugs in a pill, and it's my understanding correctly that the pill is going out and there's a new film or something, there's an oral release formulation that's going to be the new way to do it. But this combination of medicine, when given by an experienced doctor like you that has the special training, can be used to help addicts get off of these medicines and reduce overdose deaths and all this, and has strong scientific and clinical data to support its use. So I helped you with the introduction of Suboxone.
Yeah.
So take it from there. You give Suboxone to people and help them recover and turn their lives around as well.
Yes. And why I have quite a bit of passion about this. I want to not jump around. So that's why I'm taking a few minutes to think about it. And let me also add, when he says agonist-antagonist, it means a medication that will, for example, help pain or withdrawal symptoms, but then there's a ceiling effect.
Yeah.
And so the antagonist part of it won't allow it to do more and more and more. For example, overdose and narcotics. It's a harder drug to, it's a safer drug to use than, say, oxycodone, heroin, things like that.
And you're not going to have the high you're going to get from a heroin or something.
I sure don't think so. That's what they say.
It's my understanding it's not.
So let me think of my beginnings. Since I did and do write opioids some, with the opioid epidemic, they call it, I'm concerned, well, am I causing some of this problem? As I've interviewed patients over the years, I've not seen many come from pain clinics, but they may. It's not ruled out. But probably close to half of them have got introduced to narcotics post-operatively, post-op pain, and then they had trouble getting away from it. And if well-meaning doctors say, you're still hurting after, but you should be better. Well, let's give you more. And then now what do I do? Well, let's ship them off back to the family practice doctor because I'm a surgeon. I'm done with this. I'm doing this kind of care or pain management or something like that. And so that's kind of how I got introduced to it. That it's a problem.
Yeah, addiction is a chronic pain in a way.
Yeah, and so I took some extra training, not tons. It was easy to do.
And what's it called? There's a name for it when you've got a waiver. Is it a waiver?
Yeah, I'm going to call it a Suboxone waiver. And
I think it's called Suboxone waiver.
Data 2000 thing too. And there's a web address. You can just Google Suboxone providers, and it'll give you a list in your area.
And you went through this course and whatnot, and you've got the waiver.
Yeah, oh yeah.
All right, so
and so in my clinic, people would come in, and they're beat up, emotionally, and they're beating themselves up, and I often will start the conversation and said, most people, it's 72 degrees outside, birds are singing, it's sunshine, let's go for opioid treatment. They don't do that. So tell me your history. And I don't want to pry too much, but I want to kind of get a overview of what's happened. And usually their life is pretty well destroyed by the time they get to see me. And they're expecting a doctor to come down, from their almighty position, harsh on them. And they don't look you in the eye, and they're just beat up. Sucks.
Yeah.
So often they have lost their significant other and don't get to see their child. Often the family has disowned them and doesn't want them around.
They call that rock bottom, don't they?
Yeah, and very often they have lost a job. They're in bad trouble. And to say this is a character defect, I'm strongly opposed to that.
That's why I mentioned Mother Teresa would get addicted to this stuff if you gave it to her long enough.
And so they're coming in asking for help. That's strong character.
That's strong character.
Yeah. And let's differentiate between physical addiction and psychological addiction.
Okay.
Yes, Mother Teresa, if you put her morphine in her arm, fentanyl, whatever, ran it for 6 months, they would have physical addiction, which means if I cut that off, they will have withdrawal symptoms.
Okay.
Withdrawal symptoms suck. People really want to avoid that.
I've heard.
I have never heard of anyone dying from withdrawals. I've heard a lot of people want to die with withdrawals. And there's going to always be the outliers, exceptions, but it's just terrible to go through. So anyway, these people come in beat up, but they have strong character. And if you start them on Suboxone, there's a treatment or an algorithm on how to start them, and it's
established standard of care.
Yes, exactly.
You're not reinventing the wheel here. You're doing a standard
by the book.
By the book.
And but I'll tell you, if they stay on it, and usually it's after a treatment program or something like that, but if they stayed on Suboxone, usually in my experience, and it's pretty common, 3 months roughly, the significant other's kind of poking around.
So their lives improve.
Yeah, and they got a job, and mom and dad, they still love them. They're kind of seeing it change. Well, maybe we're going to give them another try. And so the people will complain that you're substituting one drug for another. And
that would be methadone, right? That's my understanding that methadone is just one opiate for another. It's just long-acting oral. Yeah. So that was the old. So this Suboxone, what I'm getting to is Suboxone should not be confused with the treatments of old, which was methadone.
Right. It's much safer. And we are substituting a medicine.
But it's not just an opiate for an opiate. It's an opiate for a blocker that has demonstrable benefit.
Right. And so they don't go through withdrawals if they stay on it. And most people want to get off of it. Okay. But it's hard to do because it's a slow process. But it's still possible to do so. And I tell my folks I want the temperature outside to be warm, and I want there's no chaos in your life. Everything's going good. Now we're going to decrease it slowly.
There's a taper.
And as we taper, if you start having cravings or things are not going well, let's stop. Pump up again. You didn't lose anything. We're going to try it again. Being successful is more important than being off that drug.
So if someone is dependent on opiates and they want to get clean, they want to turn their life around, how does a person suffering from that type of addiction find a doctor like you?
Well, one is the database. Look up Suboxone providers. And another
That's on the internet. You could Google that.
Yeah. And then the other smart thing to do is ask for treatment. And I've heard it said that people that need help the most want the least help. And people that don't need much help are always willing to take all the help they can get. But so it kind of goes against what most folks want to do. Okay. But if treatment's a good thing and gives you tools to avoid, because Suboxone is not always successful.
Sure,
we're going to have some things that don't work out.
Yeah, there's failures in every aspect of medicine.
And it's I wish it would have worked, but the people that stay on it changes their life for better. And I always one reason I do how's your life going? Why'd you get in here? Is about a year later I try to check the chart. I'll say, now you can't tell me that you haven't wanted to use again. It hasn't. You can't tell me it's not crossed your mind. Nobody would know. I could probably get around a drug screen, time it right, and I wouldn't harm anybody. I could still, try it out. Remember where you came from, how crappy it was to not see your child anymore, stuff like that. And I said, you're being successful, and that's when the pom poms come out.
Once again, you cheerlead their recovery from pain or addiction or whatever their problem is.
And one impressive thing with Suboxone is to stay off opioids. I think it's around 85% people stay off of using drugs. And that's
Wow.
that's like a miracle.
That's a miracle. So I don't know what the stats are for 12-step programs or something. It's like 20%.
Yeah.
It's the
Much lower.
minority. The minority. Yeah, you've got 85%.
It's around there. It's above 80, and so it's life changing.
That's
really helps
dramatic.
people, and they gain weight. They look you in the eye.
Weight loss surgery. I mean, that's what you're looking for. Not 100% of people will lose weight on weight loss surgery, but if you hit 80%, boy, that's approved. That's a breakthrough.
So it's changes their life, and see happy people working. Just kind of check in. We do all the stuff we're supposed to. Urine drug screens. But it's fun to watch them get better. It really is.
It really is. That's one of the rewards of being a doctor and seeing people get better. Well, Steve, I've learned an awful lot. I really appreciate your knowledge and your time. And I appreciate you as a physician. And thanks for spending the time on the Dr. Gil Show to share your knowledge.
Thanks.
Thank you very much, Steve.
There you
Pleasure.
go.